Okay, Assalamu alaikum and very good morning. Today is our continuation of our previous class. Actually, we discussed yesterday some permeation concepts from the membrane, and today we will discuss some their other aspects. Especially, we will discuss some examples which are given in the table of this chapter. And I assume that you have already understand all the concepts of the permeation regarding their passive diffusion concept, among them paracellular, transcellular, and same with the case carrier mediated transportation, and among them we understand the concept of uh, Efflux Transporter and also the other transporters, in which we assume that the movement of the uptake transporter. And these two type of the transporter will give us the further concept of the drug absorption through the carrier by the carriers. Okay, yes, especially in this chapter, we will take the example of the detail of these tables. In the table 1, which is actually table 2.1, and we have data of log p values and log d values, where we can understand the concept of different drugs. For example, we have the drugs of atenolol and famotidine and the other drugs. Especially, I will discuss the values which are highest in this table. This table is actually on the table page 24 of the book, which I have already shared in our WhatsApp group, and I will attach this soft copy of this book with the LMS system also, from the basic pharmacokinetics and pharmacodynamics, and edited by the Sara. In this case, we have an example of the highest log p value, which was ibuprofen, and their log p value is 3.72, and another example of the highest is philodipine, that was 4.83. In my previous class, I give a concept of the log p and also the log d, because in case of log p, I told all of you, log p give us the polarity, tell us about the polarity of the drug, either, and also the lipophilicity of the drug, and log d will give us the lipophilicity as well as polarity of the drug. And we assume that log p value is always higher than the log d value, because log p value is calculated by the unionized formation of the drug, and log d's are calculated by the ionized form of the drug. And for this type of calculation, we use some buffers rather than the water, and these will give us the more values of log p value as compared to log t. I want to compare this concept by using the philodipine having the log p value 4.83, and log d 7.4 value is also 4.83, but log d6 is 4.82. And same when we discuss with the other drug, which is atenolol, its log p value is 0.10, and log d value is minus 1.66, and log d that was log d 7.4, and log d6 is minus 2.70. It means values are gradually decreasing when we moving from log p towards the log d values. Another example is our valproic acid. Log p value is 2.72, and log d value 7.4 is 0.16, and log d 6.8 is 1.51. It means it gives us some concepts of the ionization form of the drug, which are at the log d values and the log p values. I hope all the students will follow my instructions by checking this table, and will learn by heart these, especially these examples and their differences of the log p and the log d values. Okay, next move towards the next table, which is table 2.2, which give us the primary locations of the major drug uptake transporter and some examples of the substrates and inhibitors. I give the concept of the uptake transporter. These are the basically transporter which are existing on the apical part of the membrane, because they are uptaking the drug towards the membrane, and these uptake transporters are basically located on the different areas. And there are some examples of, in my previous class I gave the name of the OATP and also the OATP1, B, C and OCT, and then OAT means that was our anionic form of the transportation, and OCT means cationic form of the drug transportation, and also the other PEPT, that was example of the different permeations of the different drugs. And the examples of these drugs are, for example, OATP are located in the brain and intestine, and OATP also existed located in the renal and the liver areas, while the OCT means our the cationic type of the transportation is occurs in the liver and kidney. These are the two major areas, and anionic parts of the drugs will be absorbed through this concept of the uptake transporter are from the kidneys. And in case of examples, we can say the examples of the substrate and also the inhibitors. These are some inhibitors which inhibit these type of the uptakers. We will, when we study a particular drug for their bioavailability or the bioequivalence studies, and want to know their route of administration and way of absorption, way of permeation, then we will be very much careful about the other inhibitors which inhibit their absorption or their permeation by inhibiting these uptakers. And there are the different uptakers. For example, in OATP, which are present on the brain, they can be inhibited by the fruits. And for example, in the OATP which are present in the liver, they can inhibit by the cyclosporins, rifampin and other drugs. For example, the drugs which are OCT they are inhibited by the cimetidine, which are located on the kidney. So we can assume that these drugs and all the other things like fruits can inhibit these uptake receptors, and they can influence the permeation of the drug. If we found some type of inhibition of these uptakers, it means the drug permeation of the drug will be reduced, and these reduction of the drug will be reduce the bioavailability or bioequivalence concept of the drugs. Okay, next move toward the table 2.3, which is giving us the primary location of the major drug efflux transporter. Remember, in case of carrier mediated, we learn about the two types of the transporter. One was uptake transporter and other is the carrier and the efflux transporter. Efflux transporter are basically our defense mechanism, because when the drug or the even any foreign particle approaches towards another in the area and want to pass from the membrane, the efflux process, the efflux transporter are basically those transporter which remove the drug from that area. These efflux transporter are also, we have already having the different concept of the ABC, adenosine based cassettes, and we have given them their ABC1, ABC2, 3 and 4. These ABC1 are present in liver, kidney and intestine, and ABC2 are also present in the liver, kidney and intestine, and ABC3 and 4, these are present also in the liver and the kidneys and intestine, and these are basically those type of the cassettes which involves the energy in the form of adenosine triphosphate. So we can assume that these are the basically examples of the active transportation, because in case of active diffusion based transportation, in which we have a stimuli in the form of energy, and these type of energy are coming from these ATPs based cassettes, and these cassettes will move the different drugs, especially those drugs which are efflux from the drugs are example of these drugs are some sulfasalazine and acyclovir, and also the other metformin. These are all the drugs which are directly having the some influence of the efflux transporters. Okay, the next table is example of substrates, inhibitors and inducer of P glycoproteins. Remember, these P glycoproteins are also, we say these are the permeable glycoproteins, and these glycoproteins are also our transporter and the example of the efflux transporter. They basically defense mechanism of the cellular waste, and that they remove the drug or the foreign particles, and these are they have the some substrates, for the sake of substrates, some anti-cancerous drugs, and among them paclitaxel, doxorubicin, vincristine, vinblastine. All these are the examples of the substrate of these type of the P glycoproteins. And also cardiovascular drugs, among them verapamil and digoxin and other losartan, and then H2 receptor antagonist, and all these drugs are the examples of substrates. And among inhibitors, we will read the cyclosporins, verapamil, quinidine, and these are the some inhibitors. And inducers include the rifampin. These are the example of our efflux transporter, which is P glycoproteins. So why we are discussing these tables? You people all should follow the instruction, follow the examples of these from these tables, and then you will learn it, and then we will make some type of the discussion, the particular drugs, why they are, when we want to absorb these drugs from the particular area by carrier mediation, then what are the parameters which we should have to be adopted. Either we will have to take some food with these drugs or not. Can we use this drug with another? Is there any type of the drug-drug interaction? These all information will be obtained by observing the information which are present in this table. Okay, our today's topic is drug administration and drug absorption concept. Drug administration and drug absorption concept. Remember, drug absorption starts with some first in vitro or some physical parameter, physical processes first. For example, we are giving a drug to the patient in the solid dosage form. It will disintegrate first, then make some solution, dissolve it, and then it absorbs it from the membrane. And after getting the absorption, they will be available in the systemic circulation, and they will be passed toward our different organs. What about the routes of drug administration? We will first discuss this concept, drug administration, and among them, routes of drug administration. Routes of drug administration can be divided into two basic types. One is common route of local drug administration. Common route of local drug administration. Another is common route of systemic drug administration. When there is a question, okay, explain the routes of administrations of the drug absorption or the drug availability, then we will divide it into the two major routes. One is commonly drug effect on the local drug actions, and other is the systemic drugs. In case of Local drug administration we can also divide into two parts. One is topical drug available in the form of ointments, creams, lotions, different solutions, and other is targeted non-systemic. Targeted non-systemic. For example, some drugs which are directly affect our GI system to treat some ulcer conditions, or to treat the ulcerative colitis, which is the complication of the colon. So different organs treat targeted colon, ocular, and otic area. In case of colon, the example of the targeted, which is actually locally acting drugs, sulfasalazine, which are used for the treatment of ulcerative colitis. Drug shows its local effect, but it moves from the GI system, toward, and then approaches to the colon, where the drug is available for the treatment of ulcerative colitis. And these type of the ulcerative colitis are treated by the sulfasalazine, and these sulfasalazine have the locally targeted non-systemic effect. They are not absorbed in the systemic circulation, and they show their direct effect, just like our topical preparations. Okay, in case of ocular, there is a concept of vesicular endothelial growth factor, VEGA, 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 vesicular endothelial growth factor. These are basically complications of the arteries which are present in our eye. The arteries become flat, twisted, or they swelled, and for the treatment of this VEGA, we directly inject the drugs to the eye. And these type of the treatment will also be considered the targeted non-systemic. They will not also absorb in the systemic circulation, and they are subclassed into the local drug administration, which are the example of the targeted area. Okay, in case of otic media, we use the different antibiotics, and these antibiotics are directly effect against the pathogens. These are the examples of common routes of the local drug administration. Okay, what about the common routes of the systemic drug administration? Very common is our IV injections, intravesicular injections. IV direct intravesicular direct administration, which can be divided into two: intravenous and intra-arterial. Intra-arterial are the less common examples, but some anti-cancer drugs can be introduced to the intra-arterial passages, but the intravenous injections are our most common. These are the basically example of IV direct administration. And the other example of these are extra vesicular drug administration. Okay, they can be divided into intramuscular or subcutaneous. or sublingual, which is also called parenteral. And the third type of these concept is other extravesicular drug administration. Among them, other examples are buccal root, sublingual, intranasal, transdermal, pulmonary, fast dissolving films, and rectal. This is the actual concept of our routes of administration. Basically, two common route for the local absorption of the drug, local application of the drug, local administration. Another is systemic drug administration. Okay, this systemic drug administration is maybe direct or maybe indirect. In the case of direct, we will use the intravesicular. And intravesicular means we can divide it into two, intravenous and intra-arterial. And in case of extravesicular routes, these may be intramuscular, subcutaneous, sublingual, parenteral. Parenterals are basically terms which may be used for the sake of injections in our pharmaceuticals. And the larger term for the parenteral means other than oral. But in our pharmaceuticals, we will use the words for the injectables. And other extravesicular routes among fast dissolving tablets. These tablets are basically absorbed, the active of these tablets are absorbed in the GA system. First of all, we disintegrate into the medium and then we swallow it. Then buccal are the sublingual. These are the basically example of the nitroglycerines where the drug disintegrate very fast and absorbed and the first pass effect overcome. And in case of the intranasal, we already discussed in the yesterday class, nasal membranes have the more loose junctions of their cellular base and they have their plenty of space for the absorption, especially the drugs where we want to approach the brain or to want to cross the BBB, blood-brain barrier. We prefer the use of the intranasal because through the nasal we have the direct approach toward the brain, and then transdermal, and then pulmonary. There are especially those drugs which we want to apply on our respiratory tract system, then rectal in the form of the suppositories. Okay, thank you very much.